both of which have transformed the healthcare space through their path-breaking and pioneering models leveraging technology for digital health inclusion. And with that, I'd like to introduce you to our moderator, Shreya Sethi, Country Director at the International Innovation Corps at the University of Chicago Trust and Center in Delhi. Shreya, please.
Thank you so much, Dendi, and we're looking forward to this conversation with Raghu and Professor Mamun. Just to give a very brief overview and introduction to both our esteemed panelists today, Professor Mamun is the founder and president of CMed Health, a health tech startup transforming the healthcare landscape in Bangladesh. Professor Mamun holds a PhD in computer and biomedical engineering from University of Southampton, UK, and a PhD in research fellowship from University of Toronto, Canada. He is the founder of the AIMS Lab and professor of digital health at United International University, Bangladesh. He introduced first deep brain simulation surgery for Parkinson's patients in Bangladesh. He's also a contributor and topic driver of WHO ITU focus group for AI and health, and a national consultant for the digital health systems and digital health strategy government of Bangladesh. Welcome, Professor Mamun. We look forward to having you talk and share some of your experiences.
Hello, everyone. Thank you so much, Shreya, for the nice introduction.
So introducing Raghu. Raghu Dharmaraju is the VP Products and Programs for the Wadhwani Institute of Artificial Intelligence. Over the last 2 decades at the intersection of technology and social impact, Raghu has developed, launched, and scaled innovations in AI, medical technology, rural energy, and transportation. As part of the founding leadership team, he helped build Wadhwani AI into a globally unique organization, developing AI-based solutions in TB, maternal and child health, COVID-19, and cotton farming. He's also an alumnus of Cornell, UMass, and IIT Madras. Welcome, Raghu, and we really look forward to hearing more about the products and the programs you've built at Wadhwani AI.
Thank you, Shreya. Looking forward to it.
So before we begin, I'd like to invite both Professor Mamun and Raghu to just share a little bit about the organizations. So Professor Mamun, over to you.
Thank you so much for giving me an opportunity to share today's session. So, you already give the introduction. So what we do here, we're trying to understand what are the problems in healthcare, why the people are suffering, scarcity of the healthcare, and how fourth industrial revolution technology can help to improve the healthcare. And so far, we have already reached 3.3 million people. And during COVID-19, we reached 2 million people through the digital systems and AI to actually provide the basic healthcare service and connecting them to the resources. So I'd like to share more details in my presentation, and over to Shreya. Thank you.
Professor Mamun, maybe we can just go through the presentation and then move to Raghu.
Okay, thank you so much. And I'd like to share my journey of digital health inclusion to achieve universal health coverage, that what we did in last 6 years in Bangladesh and how I are performing. So let me give you a situation of what is healthcare and what is health system. That is very important. So in the developing world, we have to know that healthcare systems actually consist of prevention, diagnosis, and treatment, which provided through healthcare systems, which includes preventive care, primary care, secondary care, tertiary care, as well as public health in the countries. But sadly, in countries like Bangladesh, the very high attention is in curative care. On the other hand, very low attention in preventive, palliative, and primary health care, as well as public health. And we've seen this situation during the COVID-19 pandemic, where the public health initiatives are so limited. So that's why you can see that this is the situation of different government hospitals in Bangladesh is patient overburden, each of the hospitals, due to there is no referral system and so on. So let me share you why this situation actually happening. In Bangladesh, we know we have 2.5% of the world population living in very tiny part of the world. And here, there is a 67% death happening every year due to non-communicable disease. And in Bangladesh, like similar other country, developing world, there is no referral systems, no health record. And due to the lack of information in our hand or in the medical system, the increases high expenditure on healthcare, as well as there is no health insurance. And also another important thing is health expenditure is huge in every year, which is more than $10 billion. So we have only 10 years in our hand to achieve universal health coverage. So if we want to achieve universal health coverage, we have to act together. So based on a one-year research in 2015, we actually try to identify the healthcare problems that I already mentioned. And we designed a solution that how can we reach to the last mile and create a digital health inclusion by giving health account and capturing their health transaction like activities and achieve universal health coverage. So that initiative we named CMED, cloud-based medical system for health system that connect people and saving lives. Let me give you the technology, how we are actually doing it. So we have a digital healthcare platforms, which is actually based on Internet of Things, artificial intelligence, and the cloud. It have the IoT-based medical devices and mobile app and the AI-based health risk prediction system, which help to monitor health screening, educate people, and assess the health risk and refer patients to their required services with the resources. And with it, we develop the health record and we can predict the future risk of stroke, heart attack, and diabetes. So let me share you how we actually implementing the model in a last mile. So in Bangladesh, we have a 4,500 catchment areas, which is called unions. So each of the unions are designed in a way that each union have a one doctor, qualified doctors, and under these doctors there is a 2 or 3 medical assistants, and under that there is a 14 to 15 health visitors who actually covering 500 households every month. So you can see here, this is the health visitor who actually go to the household with a smart medical kit and the smartphones. So provide the health screening, health checkup to every family members in their doorsteps based on their health risk that connect to the doctors at the union level, so that they can actually have a health education, preventive health care, and good primary health care and referral. So let me share the experience with a very small video how this system actually works.
Although everyone is familiar with Facebook or bank account, but few of them are familiar with the health account, where the detailed information of the health condition of a person can be stored over the decades. Health Visitor has given us a health card at only 100 taka for a year. We get health services using that card. Health Visitor came to our house and checked our health condition using smart devices. We don't need to go anywhere. We're getting health services at home. From newborn to people of all ages, everyone owns a health account in Shombhag Union. Primary health care of each person is regularly checked and followed up under the supervision of one doctor, 2 assistants, and 14 health visitors. As I'm pregnant, the health visitor gives me effective advices and I follow them regularly. A sample of blood has been taken from my finger and put it in the smart device to check my blood sugar, and they found diabetes. After finding the high blood pressure, the health visitor suggested me to consume less red meat. If there is any pregnant mother in the family, she is given iron tablets. Thus, the regular illness in our daily lives is also checked by our health visitors and doctors. And we also provide referrals, treatment, and follow-up for the patients. After analyzing the data of digital health accounts, it is observed that 16% of total population are suffering from diabetes, 11% have high blood pressure, and 25% are suffering from obesity or overweight. Once in every month, each person is screened for 10 tests and get appropriate health advices from doctors and health visitors. We will include 20 new services so that people can get vital medical tests like ECG, ultrasound, and other services at home. People will be able to know their health conditions at home without visiting to remote hospitals and can take preventive measures by knowing about their health risks early.
So you can see here, with this system, we already reached 1.6 million people that captured 51 unions. That in these 51 unions, every citizen have their health account. Every month they're getting health checkup. And if not only that, who will born tomorrow, they will get a health account after he or she born. And with that, we already created more than 1,000 jobs. And this model already recognized locally and internationally, including the Global Innovation Award in Switzerland. So you can think of that, what actually summarize this model. It actually comprehensive preventive health care, primary health care, health education with a digital platform, which creates health account for health inclusion and using the health service data for future use of improving individuals' health at their family level, and as well as national interest to actually defining resources. And you can name the services is like non-communicable disease, communicable disease, common illness, nutrition, pediatrics, maternal, adolescent, mental and geriatric health. And also on the other hand, regular health screening autism, breast cancer, Alzheimer, Parkinson, and so on. So that also include family planning. So you may think of that, how we doing it? And maybe it is very costly. It is not. And you will be surprised to know that the cost of this service is not much. When we use collective effort, the cost of this service, $1 per family per month. And we are making it. And we have a plan to reach more 100 unions this year. That will give us more than 5 million users. So with that, we are actually transforming the healthcare of Bangladesh. And also this kind of model help to actually scale in other developing countries. So potentially we call it that using our digital health inclusion model, we can actually transform 2.5% of the world population with more productive and healthy. With that, we can reduce healthcare cost and introduce innovative health insurance, reduce ancillary mortality rate. And of course, there is a referral system and health record is established. And we believe on that technology is something that will game changer and revolutionary for impacting people around the world, especially in developing world. So through the technology, we can continue the smile of these females who actually need the most. Thank you so much. Over to you, Shuraya.
Thank you so much for that, Professor Mamun. Very inspiring work, and would love to ask a few follow-up questions. But before that, maybe Raghu, you could also share a little bit about the work that Wadhwani AI has been doing.
Sure. Thank you, Shreya. Can I share my screen?
Yes, please go ahead.
It'd be good if folks can give me control of the screen so that I can share. There. It's good. Okay, so can someone confirm you're able to see my screen?
Yes, Raghu, we can see it.
Okay, thank you. So I'm going to just briefly use one example of our work to make some key points about how we should think about bringing AI to the next 5 billion using these sort of platforms that Professor Mamun is building. Whose work I must commend him quite a bit, and his organization, very inspiring indeed. But when and quickly, these are the areas of work that are currently underway. Really, the linchpin of our work is how we actually collaborate with our partners. Technologists alone, administrators alone cannot really make it change using technology. And the reason for that is simply the complexity of the challenges are such that for any meaningful innovation, it requires folks from several backgrounds, right? And this is really how we work. Now, our work tends to focus on scaled impact, creating AI solutions for scaled impact. Now, what does that mean? The kind of program that Professor Mamoon is building is an example of what you might call a scaled program. If we were to look at India, under maternal and child health, you have scaled programs such as home-based newborn care. Now, what does home-based newborn care mean? It means several hundreds of thousands, actually more like 1 million plus ashas, visit homes of mothers and children literally every day, right? And now they are the ones actually who use, when we want to use digital tools, they are the ones using those tools, right? But the benefit will not be there unless the tools are well integrated with the workflows. A simple example might be, let's say you order something on Amazon. I don't think you are worried about whether you're going to get that book or not, right? Unfortunately, such seamless integration of our digital infrastructure and data pipelines is very much an exception as opposed to norm. In fact, I would go as far as to say that most government programs are not really well integrated with their digital infrastructure, right? So when we think of as AI-based solution, we have to consider all aspects of it. It's not simply about the AI algorithm. It's not simply about the app or the product. It's not simply about getting data to that app. It's about the overall digital infrastructure and also the workforce. At the very least, you want to make sure that the upstream actions that contribute the data and the downstream actions that deliver the impact are well integrated. Now, I often get the question, how do you choose the problems you decide to work on? And we actually came up with a 7-question framework for what we call sustained scaled impact. These are obviously surface level questions, and turns out if you kind of dig deep along any of these lines, you can get into a lot more detail. So sure, you always want to start with whether it's really a problem worth solving, but do ask early on whether AI and AI-based solution is actually possible, right? AI is not something that you can use for everything. And even so, and this is a big one that I see most folks missing, will AI make enough of a difference? There are 2 ways in which AI might not actually be worth it. One is you may have a simple rule-based method or some other programming method, computer programming method, that might be good enough, right? AI might give you a little bit more, but that might not, the effort might not be worth it. The second one, more common one, actually comes to the overall cascade of challenges a lot of our problems actually have. You might do the diagnosis, but maybe you have your bigger issue is actually sample collection. Even you can do the diagnosis using AI. Or maybe your bigger challenge is delivering treatment after you do the diagnosis, right? So just putting a lot of effort in doing the AI will not make enough of a difference. The other things are a little bit more straightforward. Of course, you want to make sure there's stakeholder acceptance, including your users and beneficiaries, not just the officials, right? Does data exist? Most of the data in our public health systems is not something you can immediately build AI on. So are you willing to take on what you call the cold start challenge by actually doing some data collection through studies or some other special mechanism to get started, right? And to do all that, you need co-creators, mostly non-profit organizations often that are on the ground to help you understand the challenge, co-create, and also do the piloting. And all this is not useful unless you actually have programs and pathways to scale. That's why we tend to focus on large-scale programs within the public health system or agriculture extension system. Now, I'll quickly walk through one example. Any of you that is familiar with birth records, etc., will immediately notice that somehow magically at this particular facility, all babies weigh exactly 2.5 kilograms, sorry. The reason for that is that's the cutoff for a normal baby, and baby categorized as low birth weight and is assessed as having high risk, needs some special attention. That might be additional work, right? So obviously there are challenges around incentives and workloads that have to be addressed. But there are also other simple issues such as supply chain, cultural taboos. Using a spring balance in the field is not that easy. You see, there are 3 women there that are carefully weighing the baby, and even after all this, because of paper entries, etc., you end up with unverifiable data, right? And there's a lot of paper transcription. What we have come up with is what we call the visual weighing machine. What an ASHA doing is, or ASHA community health worker is doing here is simply waving her phone over the baby. And from that, we are doing a 3D reconstruction of the baby's shape. Turns out that the density of babies is roughly similar, and hence you can go from volume to weight fairly accurately. The additional benefit here, of course, is we get to measure other things that today field workers do not really measure, things like head circumference or mid-upper arm circumference, which are also important for growth tracking, right, and understanding risks for the baby. We also have some initial results to show that this works even in really dark and challenging settings. But more than AI, what we are excited about is the fact that we offer a way to simplify the overall system by integrating this with any app, any frontline app, and with the workflows. So data can flow to the dashboards as well as give assessment to the community health worker for appropriate action at the same time. And you can always go back and verify and geotag. So with that, let me just stop.
Thank you, Raghu. It's always fascinating to hear about the incredible work that Wadhwani AI is doing. It's like really the next frontier, right? So with that, I'd like to just, open up the conversation a little bit. And, Raghu, when we were talking earlier, you talked, I think you brought up a very interesting point, right? Is the problem big enough, right? And when we're here today, we're talking about the fact that it's universal health care coverage. We're looking at, addressing a large population. One of the challenges that, it comes across in both your conversations, you're looking at working with frontline workers to expand this, right? Do you feel like I'd love to understand how how do you think about using frontline workers, building up the digital capacity of frontline workers to actually reach the scale that we're talking about? And, question for both of you, but maybe Raghu, you could start.
Sure. What we are observing is it's not, the health system does have a way of doing capacity building and training, etc., right? But you don't know where the world itself is moving. I've been amazed by community health workers using predictive typing in Hindi using English script. At the same time, they had in their lab notebooks scribbled with data that's going to be very hard to read, right? So I think I honestly feel to some extent, the system is behind where the capabilities of our health workers already are. And I'm sure Dr. Mamoon will have his own perspectives. I'm not suggesting that every place is equally ready, but I'm suggesting that we are not moving as fast as we could in introducing this and making a shift.
Yeah. Professor Mamoon, I think you're on mute.
Thank you, Raghu. And I think Raghu already made my life easy because he pointed out that how difficult to get the data from the field level. So what happened? There is a lack of transparency, lack of accountability, and lack of quality of data and lack of quality of service. So if we want to overcome such situations, there is no manual method can solve this. We have to take the advantage of technology. So you can see that instead of taking the audit with a pen and paper, he developed the things that with a picture, they can calculate the a audit of the baby so that we can take measure, right? Similarly, in our perspective is before utilizing the smart platforms, we always found that everyone's blood pressure is always 120/80. So that is not possible, right? What we did, we use IoT-based all the medical device. So there is no options to make a data entry. So just what did they do? They have to create the health account for the first time. And every time they go, we actually track all the health workers, which route they use to go to the doorsteps. And we take the GPS location that if they are in there. And we also take that how they measure the blood pressures, and immediately our the clinical decision support system provide that what counseling they will provide. So what actually it brings? It brings transparency, it brings accountability, and brings quality of service. And we are getting quality of data. That is very important to train any of the AI system to actually develop future risk prediction models. On the other hand, this data is so important to design resources, planning resources for the government policymakers, that what measures they have to take for the next 1 year or next 10 years in particular areas. So you see that with the tools and techniques and technology, we can aid our health workers very efficient, very productive, so that we can actually go towards achieving universal health coverage, that is no one leave behind, and we can actually reach everyone in the last mile.
So Professor Maman, you brought up an interesting point, right? That some of the data you're collecting is towards, having policymakers and regulators make better decisions. And you work closely with the government of Bangladesh. Are you seeing that happen? Are you seeing a regulatory framework which is conducive to digital transformation of health?
If I say about the Bangladesh context, Bangladesh is a forefront in digital transformation. Our Honorable Prime Minister actually had a mandate in 2008 to make digital Bangladesh. And with that mandate, we actually transform digital Bangladesh, especially in fintech and other aspects. Health tech was not that much, but last few years, we are focusing on health tech. And with that, we actually developed digital health strategy for achieving universal health coverage. And also our government is very much interested to digitalize all the health services so that we can ensure accountability. However, there is a lot of things need to be happen over time. But what I say, in Bangladesh and India and other countries, there is a digital mandate, digital initiative by the government really helping to actually developing the system and adapting systems so that the government can actually ensure service to the people. And digital system help to develop the service that is population centered, rather government centered, or rather physician centered. So that is very important.
Right. And Raghu, similarly, right? Like, I mean, we've been working on projects together where we're trying to essentially work and build up the capacity of government to understand AI. And in a country, I mean, with technology, the problem is technology seems to be changing faster than policy can keep up, right? So where do you see where do you see the path forward for a regulatory framework to enable more such innovations?
See, I think the regulatory frameworks coming into place quite well, especially in India. You have the National Digital Health Blueprint that's come into place. There's a National Digital Mission that's forming. All that's coming in place. I'm sure that and I have a sense that that will be worked out quite well. I suspect that the challenges will be in actually turning these frameworks into reality, right? And we've seen this as a challenge, even I should say in our last wave of what we hoped was digital transformation, right? And that has left us with, quite honestly, patchwork of digital adoption, so to say, right? Interoperability was a challenge. So I think the point you touched on early on, which is building capacity within government through mechanisms to really transform these high-level strategies, visions into plans that are executed on, right? In a way that clarifies strategic priorities for the outside innovator world, seeks those innovations, evaluates and adopts them on some roadmap, right? And the consistency of these roadmaps is extremely important. I'll give one example. In 2017, we had the National Health Policy laying out our priorities, right? One of them was the health and wellness centers. Another one that was associated with that was actually all Ashas getting phones and things like that. We are still behind on some of them. Yes, we've been set back by COVID, but I think we'll have to redouble our efforts.
I think we have just time for one more question, so I'm going to ask you both this. Fundamentally, you're talking about technologies, IoT, AI, that people that you're working with, don't understand, right? So you're going to a woman and saying, wait, I want to take a picture of your phone. Do you face a lot of resistance on ground with like fear of technology and, resistance to change?
Uh,
Professor?
Thank you, Shreya. I think this is a very important question. This is about the cultural adaptation. So at the beginning, we faced the same problem during 2017 and 2018. And there is a fear that they will lose the privacy, even though they don't understand the privacy. So like with the education, actually, this is actually changing very rapidly. And here, the one thing we have to educate people. You see the picture in the hospital, government hospitals in Bangladesh, that there is no beds empty, like all the floor corridors are with the patient, right? Why it's happened? Like what I believe that if we do a proper health education, health screening, and good primary health care, so that we can identify their health problems very early stage, so we can prevent in the initial stage, so that we can reduce the burden, because no country can avail to like have an unlimited cost for the healthcare. So only solution is prevention. So if we do a prevention, then we can manage. When we have a less load of patient, we can manage very well. So this is like a mantra for the developing world to actually emphasis on the prevention and good primary health care. That actually create the foundation to the healthcare system.
Thank you, Professor Mamun. What I'm hearing from you is we need to invest in actually, making the people understand the changes as well, educating the benefits. Yes. Raghu, any words from you on the challenges on the field?
I'll actually use a counterpoint. When we go through programs, we find that trust is very much there. One thing I actually worry about is too much trust in AI-based systems, and people not using their judgment. Right? So that's actually a counterpoint. So, and it's a you got to kind of figure out what your balance is based on the specific use case, and that is actually a key part of how you design your AI-based solutions.
I just would like to add one thing with Raghu, that AI can be aid to the health system, but AI cannot solve alone anything, any diagnosis or any treatment. It's an aid to our health system.
Yeah. Absolutely. And both of you talked a lot about partnerships. You both talked about the fact that we're essentially using frontline workers, a very human touch point to actually deliver this technology, and that is not something that we're going to lose anytime soon, right? So thank you both of you for this conversation. Unfortunately, this is all the time that we had. While I would have loved to ask you many more conversations and questions on this, maybe some other time. But I think both of you leave me with a sense of hope that it might be some time away, but with the right framework, with the right kind of passion, and the hope that you both bring, we will be able to use technology for universal health coverage, sometime soon. So thank you so much for that, and thank you so much, AVPN, for bringing up such an important topic of conversation. We hope it was a useful conversation. Back to you, AVPN team, with that.
And Shreya, I just would like to add one sentence, that we want to see that in 10 years, every citizen have their own health account in the world, not in Bangladesh or not in India. Thank you.
Thank you.
Thank you so much. Thank you, Shreya. Actually, thank you to the three of you for joining us today. With that, we have come to the end of this session, Digital Health Inclusion to Achieve Universal Health Coverage. This session is made possible with the kind support of our festival partners, Bill and Melinda Gates Foundation, Sesame Workshop India, the Rockefeller Foundation, COVID Action Collab, VNV Advisory Services LLP, the British Asian Trust, WPP India CSR Foundation, Catalyst Management Services PTE Ltd, and Sarwa. We encourage you to continue chatting with your speakers and fellow delegates in this session, so please make full use of the messaging and meeting function on our festival platform. Do share your highlights of this session on social media, and remember to tag us using the hashtags #AVPN South Asia 2021 and #SocialImpact. Up next, the session on improving access to affordable healthcare through critical investments will be starting at 5 p.m. IST. Thank you, and please enjoy the rest of the festival.